I don't think I've ever been consulted for the chief complaint of eye pain. It's just not something that you see a lot as a neurologist. But eye pain, in addition to other neurologic symptoms, eye pain that worsens with movement, eye pain with diplopia, eye pain with loss of vision, that's not all that infrequent. I got 2 calls about that from the ER today alone. And you should know what to do about that, especially if you're a neurologist. Hey podcast listeners, Jim Sigler here for Brainwaves, recording from Studio 3 in Philadelphia. This week on the program, I'm speaking with a neuro-ophthalmologist about her experience addressing eye pain in a neurology subspecialty clinic. From dry eye to cavernous sinus pathology, we'll cover a broad differential and a simple approach to this common chief complaint. Don't go anywhere. Dr. Ahmara Ross from the hospital at the University of Pennsylvania joined me in the studio to discuss this topic.
My name is Dr. Ahmara Ross. I am in the Department of Ophthalmology and newly in the Department of Neurology at the University of Pennsylvania.
And she's completed fellowships in both neuro-ophthalmology and glaucoma, which gives her the expertise to give this talk in particular, because she sees a lot of patients with eye pain and suspected glaucoma. And it turns out to be other things. Neurologic things. So I asked her about what this means, or what it should mean to a neurologist.
Well, it's an important question. Eye pain is super important in terms of a complaint that patients come into the clinic with. And it can be challenging because it's a pain in the eye, but it's often a manifestation, as you mentioned, of a neurological disorder. And so if a patient with eye pain shows up to a neurological clinic, the differential might be totally different than if a patient with the same eye pain shows up to an ophthalmologic clinic. And so for me, that particular complaint is a very perfect merge of neurology and ophthalmology, which can be good and bad. It's challenging for the clinician.
Yeah, so I guess, if I were to liken this to any other condition, somebody comes in with wrist pain and they came to a general practitioner, it would be different than if they went to an orthopedist because they've already been kind of triaged by some other practitioner who has some subspecialization within that discipline. In neurology, if somebody comes in with ocular pain to a neurologist, I assume that most of the ophthalmological causes have been excluded.
Yes, that's a fair assumption. But I also know that in my own practice, that's not always the case. And part of it is because it's hard to get to see a neuro-ophthalmologist. And the differential that a neuro-ophthalmologist might come up with for an ophthalmic manifestation of a neurologic disease or even an ophthalmic manifestation of disease might be totally different. For example, if a person shows up to a general ophthalmologist, they might be thinking, is this an ocular foreign body? Is this dry eye? Is it something infectious? Is it something inflammatory? They may think about angle closure glaucoma, but not always. They may think about optic neuritis, but not always. They may think about idiopathic orbital inflammatory syndrome, but not always. They also should be thinking about secondary non-ocular causes that might just be a subjective manifestation through the eye, like migraines, primary headache disorders, GCA, an intracranial bleed, cavernous sinus pathology, meningitis. All of those things can present with eye pain.
So a patient comes to your neuro-ophthalmology clinic and they present with eye pain. It's a very common, simple complaint. It's probably oversimplified to you. What is kind of your review of systems that kind of shapes the way that you build a differential?
Well, first I ask about red flags. New headache. Has this person had eye pain before? And if they have, or headache pain, is this different or the same as what they've felt in the past? That kind of gives me a level of the acuity of the person's complaint. In an older person that has a sudden and severe headache that they haven't had before, well, I might be calling you because that
Worst
to me
headache
is
of life.
right. That's always very concerning to me.
Concerning because eye pain and worst headache of life make you think about subarachnoid hemorrhage or pituitary apoplexy.
I also ask about patients that the pain wakes them up from sleep. And that is a general medical issue. If you have stomach pain that wakes you up from sleep, there's a problem. That's something that you want to make a little more acute. Mm-hmm. Patients that are older, I worry about. Patients with complex medical histories like cancer.
Cancer, because it suggests leptomeningeal carcinomatosis, or orbital or intracranial metastases.
HIV.
HIV because of the risk of toxo, CNS lymphoma, or cryptococcal meningitis. But uncontrolled HIV also carries its own risk of opportunistic eye infections, like CMV retinitis, which affects 20% of AIDS patients and is associated with a high rate of retinal detachment. Or more rarely, HIV can cause things like zoster ophthalmicus, cryptococcal optic nerve involvement, or ocular toxoplasmosis, which frequently co-occurs with intraparenchymal toxo.
Systemic conditions like polymyalgia rheumatica.
For obvious reasons, 10 to 20% of cases are associated with giant cell arteritis, but this is a painless vision loss, although many patients will also complain of headache, or jaw pain or jaw fatigue with chewing, claudication.
Those are things that I worry about. And then here's where the subtle difference between a general ophthalmologist and a neuro-ophthalmologist is we are trained to do a complete neurological exam, including cranial nerves, reflexes, motor testing, etc. And if I find any abnormalities in that also highlights my level of acuity from a patient's complaint. That brings me to a different sort of algorithm thinking about the patient's complaint. That's different than what I would be thinking as an ophthalmologist.
Because if there is a focal deficit, besides just the extraocular motor impairment or monocular vision loss, it might draw your attention to an intracranial process, or something that affects the eye and the peripheral nerves, something in the subarachnoid space, for example.
So there's that. And then from a clinical exam standpoint, really I define my differential and acuity of the complaint is if they've lost vision. That's really the most important question in my mind. Once we think about vision loss, and even if you want to practice on a patient that doesn't have vision loss, I think about examination of the eye from the outside in. So before I reach for my direct ophthalmoscope, I am doing what all of us can do, which is inspection. I'm palpating.
Assessing for intraocular pressure. I'm testing myself right now, actually, while she's describing this.
I'm seeing if there's any pulsations. I'm listening with my stethoscope to hear any bruits.
Which might tell you if there's a carotid cavernous fistula, or an aneurysm, or other vascular malformation.
I'm looking at the patient from different angles to see is one eye popping out. Suggesting
mass effect behind the eye, as you might see in an orbital varix, a fistula, tumor, or thyroid eye disease.
Lid lag ophthalmos, all of those things are also thyroid in nature. And so you treat the dry eye by all means. But someone with thyroid disease can have loss of vision because of really thick muscles.
Conversely, is there enophthalmos?
Is one eye popping in?
Usually late, following traumatic orbital injury, which is associated with pain due to reduced blinking and dry eye.
Where the person may have had a headache and have had chronic sinus disease, and it causes the sinus to shrink or collapse, and that can cause enophthalmos. I'm looking to see if they have any lid retraction that might indicate something like thyroid disease for why they have eye pain. Also, I'm examining the eyeball itself. Is it red? Are there vessels?
Suggestive of conjunctival injection, as in viral conjunctivitis. Or if there are engorged vessels, is there a CC fistula or scleritis? Could the patient have superior vena cava syndrome or increased intraorbital pressure from a cavernous sinus thrombosis, thyroid eye disease, or an orbital mass?
Then you are more than welcome to reach for the direct ophthalmoscope because you've inspected the outside surface of the eye. You've looked at the skin around the eye, the orbit. You've looked at whether the eye is poking out. You've looked at the eyeball itself. Now you can look inside the eyeball.
And speaking of what a neurology resident or a neurologist can do in the clinic, what would you expect a neurologist to do for a patient who presents with eye pain?
Well, every neurologist that I know of has that, what do you guys call the JAR guide, right?
The resident's handbook.
The resident handbook.
The basic approaches in neurologic illness.
Right. And
the JAR guide is this handbook that we give to all our newly minted PGY2 residents at Penn, who we affectionately call JARs, Junior Admitting Residents. And this book has a Snellen chart in it, among other little tips and tricks. That's what Ahmara is referring to.
And so you can always start there. If the patient has right eye pain, left eye pain, you're going to test both. So you have a comparison. Have them cover one eye, and I see how far they can read. Subtle things, if the patient's 60 and they're reading at a distance, the reading may not be 20/20 in either eye because they have presbyopia or they're not able to read.
In this situation, you can correct for the refractive error of the aging lens by the pinhole test.
You can always take a large paper clip and poke it through an index card and ask the patient to look through the hole. And that should actually...
In doing this, it's kind of cool actually. You limit the rays of light so that they directly pass through a single hole rather than scatter across a lens whose muscles are too weak to bend the light appropriately. By using a pinhole, the parallel beams of light are now able to travel through the cornea and the lens and then land on the retina without bending in all kinds of directions, roughly speaking.
That's the pinhole testing. You got it.
Okay, and if somebody comes in with eye pain and has poor visual acuity, even with pinholing, what kind of things are you thinking about?
Well, I'm thinking that this is not just dry eye. I'm thinking that this is not cornea. I'm thinking that this is not a cataract.
All these things should correct with pinholing. Dry eye, corneal irritation, cataracts.
I'm thinking that this could be potentially irreversible vision loss that could be primarily ocular, but it also could be a manifestation of a neurological issue. There's actual nerve damage. And so another loss of vision test that I use is peripheral vision and color vision.
And you can download, a card or something, an app on your phone that can go through
Absolutely
8 color plates, 12 color plates.
That's right. That's right. And even, my aunt was recently hospitalized for a pituitary apoplexy, and I was testing her visual fields. They have apps on your phone and on your computer that can actually map out your visual field defects.
So why even send a patient to your clinic if we can do this on the phone?
Because honestly, the person who trained me, Grant Lew, said you would think that would decrease the amount of consults I get. But the problem is that actually increases it because there's a very high, false negative rate or false positive rate of people that have problems with just doing the test on the computer. And you get an abnormal test, you don't know what to do with it, I'm going to get called anyway.
Okay. So simple things, if there's a loss of visual acuity in the setting of eye pain and they have normal visual acuity to pinholing, then you got to think something's wrong with the retina, something's wrong with the optic nerve.
You got it. The only thing that's often forgotten, not by neurologists, but by ophthalmologists, is a cranial nerve exam.
And I'll interrupt here again because this point can't be stressed enough. Assessing extraocular movements, pupillary abnormalities, and especially getting a reliable fundus exam to visualize the optic disc can give you tons of useful information as to why the patient has eye pain. Do they have eye pain and a sixth nerve palsy to suggest some sort of intracranial hypertension or mass? Do they have eye pain and a partial third, fourth, or sixth, suggesting an inflammatory process of the mass within the orbit? All this could be telling.
And one of the cranial nerves that we think about, but that we don't really test or we don't think about testing, is the division of the fifth nerve, particularly what's going into the eye and innervating the cornea. So when someone has right eye pain, that could be the ophthalmic division of cranial nerve 5. And so the things that I do in the office when I approach the exam is I'll take the proparacaine, which you guys don't have, and that's okay. And I'll put it in both eyes and I'll say, look, do these feel the same?
Proparacaine should sting the eye.
Do you not feel the proparacaine in the eye that is painful to you?
I've never done this personally.
Why is that important? Well, now you don't just have the optic nerve that's affected, but you have cranial nerve 5 that's affected. And so you start trying to localize it based on your clinical exam. I'm thinking about cavernous sinus pathology. I'm thinking about raised intracranial pressure pathology. Maybe the person has like a false localizing sign.
This would be due to a sixth nerve palsy with horizontal binocular diplopia.
Double vision. Ischemia to certain cranial nerves can cause it. Inflammation to the meninges can cause multiple cranial nerves to be involved. And then there's idiopathic orbital inflammatory syndrome that I'm thinking about.
Also called the Tolosa-Hunt syndrome. But we're getting ahead of ourselves. There's still more from the clinical history that can inform you about what's going on with the eye pain.
There are patients that come in and they have excruciating eye pain. I am not in any way downgrading that complaint. And if they have normal vision, normal cranial nerves, that doesn't change that it's really affecting this patient. I'll give you an example. One time I scratched my cornea. Well, actually, my son had a toy and he hit me in the eye, and I didn't think there was anything wrong. It took a couple of minutes for it to really creep up. But let me tell you, it was the worst pain I've ever felt in my life. And I birthed a child. It is painful. And so when these patients come in with eye pain bilateral, even if it's for something that you or I might not think is that acute, it's dry eye and it can be very debilitating to patients. But if there's no loss of vision.
In addition to antecedent trauma, which can lead to corneal abrasions or foreign bodies, there are a few other pertinent review systems that Dr. Ross likes to check for. Things like fevers or chills, which might make you think of some systemic or inflammatory process. Eye pain that worsens with movement, as you might see in optic neuritis. Eye pain with a pulsatile sensation, which might make you think of a fistula that you see following traumatic injury, or an ophthalmic or ICA aneurysm. History of migraines with new eye pain or blurred vision, maybe that's an ocular migraine.
No headache.
And we already covered eye pain with loss of vision or with diplopia. And, with this in mind, I can imagine that identifying an ocular migraine or any other kind of migraine or tension type headache even, they're really poorly localizing, what can a neurologist do to reassure him or herself that that's what's going on?
I think a good review of systems, I think a good medical history, start there. Healthy person that comes in with eye pain, no loss of vision, no cranial nerves, no headache, you're fairly certain that this person is probably going to be okay. Older patients scare me just as much as they scare a lot of other people. And I think that it is always good to have collaboration. There are plenty of neurologists that call me on the phone and say, hey, I have this patient in res clinic. Do you think this is something that you need to see today? I would like you to see him. Because you're there, you're seeing the patient, I'm not. And usually when I'm asked, I see them. As far as the acuity of the complaint, no cranial nerve issue, no loss of vision, no headache, still needs to be seen. The patient has a complaint and you're not able to give them a reasonable management for what the complaint is, but it's not something that needs to be seen the very next day. If you're a patient and you have eye pain, I would say push the system. If you know your complaint is getting worse, then you have to let us know. And sometimes that history is not forthcoming. Pain that's getting worse, a crescendo pain, those are things that even if I think it's nothing, I still want the patient seen. And if you can't get them in with a regular ophthalmologist at a regular appointment, you send them to an emergency room that has an ophthalmology structure already intact so that they'll be seen.
Main test through this door, make 2 rights, get the doctor's name and the page.
We've covered a lot so far, and we're about to wrap up the show. But there's one more condition that I wanted to cover with Dr. Ross, seeing as she is a specialist in this disease. And it's something that mimics a lot of common neurologic complaints: glaucoma.
Because patients come to the neuro clinic with migraines, and angle closure glaucoma can present with eye pain that is similar to migraines. When you're examining the eye, there is a part of the eye that is called the angle. If you think about the eye as a 3-dimensional structure and you cut it in half, there's the cornea, and then there's the iris, which is the colored part of the eye. And the angle that those two structures make is what we're talking about with angle closure glaucoma. That anatomical structure becomes extremely important because that's how fluid is drained from the eye. When it's narrow, the fluid can't drain. Further complicating matters is that the fluid in the eye is made behind the iris, and it's supposed to float up into the anterior chamber, which is in front of the iris, and drain into the angle. And when someone has angle closure, the iris flops down on the lens, so the fluid that's being made behind the iris can't get out, and it just makes the angle even more narrow. So if you're going to examine it, I teach residents, because you don't have a slit lamp, you don't have a gonio lens, and I wouldn't expect you to use it.
I'll jump in here by saying that I don't carry around a gonio lens, and I don't know how to use one, but this next part might be helpful to you.
But you do have a light. You can take a tangential light and shine it on the side of the patient's face, the temporal side. If you see shadowing, meaning the light is primarily on the temporal side, but on the nasal side, it looks a little dark, you could assume that the angle may actually be narrow.
Meaning they're physically unable to drain fluid from the eye, causing pressure to build up in the eye and cause pain and even permanent vision loss.
And if a patient has narrow angles, that is an acute ophthalmic emergency. Because the modalities that we have to address that issue, it's better that they have some vision than for them to go to bed at night and wake up with no vision, or God forbid, go someplace where they're dilated.
Do they present in clinics where with the chief complaint of vision loss and eye pain, or just
Not
isolated
always.
eye pain?
Not always vision loss. And that is because people can have periods where the angle's open and periods where the angle's closed. The classic story is a young guy that goes to the movies.
I'm a reporter. I follow people that do not want to be followed.
A word of caution, do not listen to this next part if you like going to the movies.
That end up killing people.
Your time to go.
He goes to the movies, the lights are on, the pupil's small.
We call them symbiotes.
The lights come down, he watches the movie.
We are Venom.
Everything's fine, pupil's large. But then the lights suddenly come on after the credits. The pupil tries to get small again, and it gets stuck. That patient can go into angle closure. Another story is a patient put on Topamax, and that can cause a narrow angle. Patient put on Diamox, and that can cause a narrow angle. And you don't think about these things. The loss of vision certainly happens, and it can happen acutely if the angle is completely closed. But the angle in the eye is not something that's always open or always closed. There can be an intermediate, and that's when patients come in with primary complaint of eye pain, and the vision loss is often subtle. But when you test their visual field formally with like a Humphrey, it's not always intact.
If there was like a message that you could give to neurologists out there about how to assess for ocular pain as a neurologist, not as an ophthalmologist, but as a neurologist, and not to miss like simple ocular things that an ophthalmologist would find, but also not to miss things that a neurologist should be able to readily identify, what would you leave us with?
Checking the vision, often forgotten. Touching and palpating the eye, often forgotten. Inspecting the eye, often forgotten. Those are the really, really important things. I'm thinking about, Jim, if this patient came into your clinic, well, not your clinic, but the resident clinic with the complaint, and you picked up the phone and you said, hey, Ahmara, this patient needs to be seen. This is what I'm seeing. Those are very, very simple, easy things that are often forgotten, but I think they're super important in terms of broadening your differential. And even if you can't tell the patient what's going on, what's wrong with them, at least you can tell them, I think this is a primary eye issue. I'm going to call an ophthalmologist and get you seen. Because then the patient feels like their complaint is being taken seriously, which is super important for our Press-Ganey scores.
Yeah. In some way, you're treating the patient.
That's right. And then from a secondary standpoint, when there's something that we as doctors don't know the answer to, or can't generate a full differential, or can't test for, we actually don't sleep well at night. Those are the patients that keep us up. And so those are simple inspection things. And then I'm always happy to see a patient that someone at Penn decides that needs to be seen. I think most of us are, but we often don't pick up the phone anymore. The idea of phone consults or communications from doctor to doctor has sort of been lost. And I kind of think it should be brought back. I think if Ali has a patient that he's concerned about, he'll pick up the phone, he'll call me. So should you, and so should any of the neuro residents. I'm happy to see that patient.
At the end of the show, I'm going to give out Ahmara Ross's personal phone number, so be on the lookout for that.
Well, Hupp has actually done that before.
It's not surprising. Again, Dr. Ahmara Ross. I'm not really about to hand out her phone number right now, but it was a really kind gesture. And this has nothing to do with the show, but I think that we should all be that collaborative with each other when treating our patients. There's a lot more we can do for them if we work together, rather than if we were to just say, oh, this seems like an eye issue, not my problem. So again, really grateful that Dr. Ross could join me on the program this week. Anyway, I know that I learned a few new things on this week for the show. I hope you did too. The Brainwaves podcast is produced out of Studio 3 in Philadelphia, Pennsylvania. Jim Sigler, senior producer. Music for this week's program was courtesy of Jan Terrien, Unheard Music Concepts, Steve Combs, and Scott Holmes. Sound effects by Mike Koenig and Daniel Simeone. If you haven't found us on social media, you can always follow us on Twitter at Brainwaves Audio, Facebook, or email us at bweditorialboard@gmail.com. I'm Jim Sigler for Brainwaves, and I'll talk to you soon.